So one of the questions, Dr. Nash, is where did you get the sharp red tie and pocket square? You look snazzy.
Deborah, uh, this is from Lords of London.
Okay.
We went
So
on.
I'll start it. Let's go ahead and kick it off with that question. And the burning question I think everybody wants to know is, do you have pants on, Dr. Nash?
No,
No?
it's not necessary.
Okay.
Only necessary clothing.
Yeah. Okay. Let's go ahead and get started.
All right.
So again, thank you all so much for joining us, giving up a part of your day to spend time to hear from Dr. Nash, Brent, and myself, but mostly Dr. Ross Nash. So we trust you're all safe and healthy. And again, we're honored that you've chosen to spend part of your day with us. So let me make just some quick introductions before we turn it over to Dr. Nash. So in the lower left-hand corner, you see Dr. Ross Nash. He's been in practice for over 42 years. So don't let the youth that he's showing belie the experience that he has. And I've seen Dr. Nash personally in action numerous times. He's written many, many articles. He's spoken worldwide on cosmetic dentistry. I think it would be fair to say that he's a pioneer and a father of the cosmetic dentistry revolution. An example of that is this. Dr. Nash is a member of the AACD, the American Academy of Cosmetic Dentistry, which unfortunately had to cancel their meeting this year. So we're bringing some of that information to you. The AACD has 6,300 plus members, and of which over 400 are accredited. So to be accredited, you have to go through an exhaustive process to do that. That could take a couple years. To be a fellow in the American Academy of Cosmetic Dentistry, of which there's less than 100 worldwide. So imagine this, 6,300 members, 400 plus accredited, there's less than 100 that are fellows, and Dr. Nash is one of those fellows. And he had to present 50 cases to the American Academy of Cosmetic Dentistry in order to get fellowship. So the information he's going to provide us will be really good information. He also runs and is obviously the founder of the Nash Institute for dental learning. So he'll provide you with some of the information that he does with the Institute. So like you probably saw in my story, we don't have to travel to Charlotte today. We're getting that from the comforts of our homes. So we're really pleased and privileged to have Dr. Nash with us. Next is Brent West. He's my business partner, and he's in El Dorado Hills, California at our main lab there. And Brent has over 25 years of experience, and he heads up our team. We do have a team of labs, one in Vancouver, Canada, and one in Wisconsin. And Brent's really the driving force, the mentor for a lot of us for what we do as a lab. So I tried to estimate the other day, because of Brent's experience in all of the cosmetic dentistry cases that's come across his lab that he's personally looked at and evaluated, I'd say that number is over 24,000. Does that sound fair, Brent?
We figured that out. That's about it.
Yeah.
I've been fortunate to be around this for a while now.
Yeah.
Yeah.
Can you imagine 24,000 cases that's come across Brent's hands and eyes? And so that's a lot of experience that he's been able to pass off to his teams in order to accomplish what we try to do to help our doctors. So thank you, Brent, for taking time to be with us. And then I'm Gil Villavisier. So I handle, basically, if you think of it, Brent handles the inside of what goes on in the lab, and I handle the outside. So I handle the marketing, I handle our programs. I've got a team that also helps me. And what we're all about is trying to promote cosmetic dentistry through our dentists, okay? And you'll hear a little bit more from me later on here. So a couple of housekeeping things. Tap on the grid view in the upper right-hand corner of your screen so that you can see all three of us at the same time, so that it's not bouncing around whoever's talking. And then two, if you have any questions, put them in the chat room. We'll compile those so that at the end, when there's questions and answers, much like the question about Dr. Nash looking sharp with his red suit or his red tie and his pocket square, we'll compile those and then we'll get to those at the very end, okay? So without any further ado, Dr. Nash is going to talk about the current and future side of cosmetic dentistry, how to position yourself as a cosmetic dentist, and then go into some case presentations where he and Brent are going to speak. So thank you very much. Dr. Nash, it's all yours.
Thank you, Gil. I appreciate that. This trend be towards cosmetic and aesthetic dentistry all really started back in the late 70s. I graduated from dental school in 1978, and I was right in the middle of all that. And it was really exciting to me because I was an engineer before I was a dentist, chemical engineer, and I had studied resins and colors and those types of things. And this just happened to fit right into my comfort zone. So I began studying from people like Buddy Mopper and Norman Feigenbaum and Paul Belvedere and Ron Goldstein and Erwin Smigel and all of those pioneers that were doing these things back then. And I got so excited about it. And I realized not only could I provide health treatment, be a doctor, aesthetic for function and health for my patients, which is my responsibility as a doctor, but I could do something else for them. I could help people with their self-esteem. And I would get smiles and hugs and kisses and bottles of wine and thank you notes for the aesthetics that I did. And that gave me a lot of reward right in here. It wasn't about the money. It was about really feeling good about what I did. So I started focusing on that early in my career. I was kind of the dental rebel, the bondodontist they called us back then. Now everybody's doing it. So anyway, over the years, I built a practice that was focused on aesthetics. We are a general practice, and we definitely focus on health and function first. But we do a lot of aesthetics, and I'm 72. I don't plan to stop doing this till I can't. And you know, these hands are pretty. Look at that; they're not shaking a bit. So I'm going to continue to do that. And I think the demand for aesthetic dentistry, and Gil can tell you this because he's been in teaching institutes. Had one of his own, not Gil, Brent, had one of his own at Frontier, where they would actually bring patients, dentists in and treat patients and that type of thing. So he knows, and he's worked with Larry Rosenthal, and he's worked with I think Hornbrook. Am I right?
Yep.
And, so this man knows about aesthetic dentistry. He was growing up with us, as a matter of fact. He's a lot younger than me, but he was growing up with us. And it is ever demanding. Now, through this coronavirus times, you know, we've had some time to think and to kind of sit back. And for me, it's kind of a time to reboot, to be honest with you. People are calling us about dentistry still, and we've been closed for a couple of weeks. Of course, we're going to open back up. But, you know, the questions aren't on, I've had a couple of patients with emergencies, but the questions are on aesthetics still. And I think it's a never-ending process. People want to look good, and it makes people feel better, more successful. It's just begun, actually. So I think there's a really good future for cosmetic and aesthetic dentistry. Cosmetics elective and aesthetics is needed dentistry that looks good. So, Brent, I think Brent, he's my smile designer. You know, there are a lot of labs between Huntersville, North Carolina, Charlotte, North Carolina, where I live, and El Dorado, California. A lot of them. But I send my work out there for a good reason, because it takes a team. It's not about the dentist. You know, the thing about direct composite, which is, you know, another part of aesthetics and cosmetic dentistry, is that the dentist is the artist. But in this case, you can hire an artist. And I've got the best in the country with that guy right there. So what do you think? What was your history there, Brent?
Yeah, you touched on it a little bit. I happened to be at the right place at the right time when we started. I just had 25 years last fall. We got invited to be part of this small little thing at the time called PAC Live with Dr. Hornbrook and Dr. Michael Kozarski back in the mid-90s or so. And then I happened to get involved with this guy named Dr. Larry Rosenthal. Kind of a little character of a dude, and I just happened to be at the right place at the right time. And so myself, for the first 5 years of my career, I was able to be chairside for prep and seating of, you know, literally hundreds and hundreds of cases at PAC Live in San Francisco, Aesthetic Advantage in West Palm Beach, New York, and London, and just got to see it over and over again. Then started working with Dr. Nash and everything. It's pretty much, you know, we just keep on perfecting what we've learned, and you're really trying to make it kind of a process and such. And I think over the years, the thing that I have noticed is that the people that are successful in this stick with the process and not really cut corners and such, and to get a predictable result and have an understanding. Whether you work with my team or you have a laboratory and stuff like that, I think it's always good to really chat about these cases for a few minutes so we understand, what the doctor's looking for, what the patient's looking for. And we can touch more on that as we get kind of into the lab communication and such, and, for all the cases that Dr. Nash and I do together, we chat about every single case briefly. Yeah. Sometimes, usually what it is, because I'm on the West Coast, he's calling me on his way home, and I'm taking notes and such. And there's many different ways to do it, but the communication is key to be able to talk to somebody to be able to make sure we're on the same page. So we can get
patients, I'm sorry, my patients are impressed when I FaceTime Brent, and he'll answer anywhere he is. You got to be careful what he's wearing, obviously.
Yeah, but, sometimes it's 5
even Saturday morning at 6 a.m. or 7 a.m.
We've had so many Facebook conversations with the patients, and they're very impressed with that I'm actually talking to my lab on the West Coast. So anyway, thank you, Brent, for all you do. It's definitely a team, no question about it.
Yeah, and I've got a great team behind as well, too.
Yeah. The thing about this type of dentistry is health and function comes first, and it's got to be there. It's not going to work, and it's not good to do. However, the aesthetics is an art. You heard about the art and science of dentistry. Well, aesthetics is a little bit more art. You still got to have the science, or it's not going to work. And I have sought out some of the best artists in the country. Actually, I recruited Brent or Frontier Lab because my wife, Deborah Englehart Nash, actually was doing some seminars with them in their institute that they had at one time. And when it came to do her work, she said, no, I want Frontier. And once I saw the work, I never looked back, buddy. So way to go. So, there are a lot of things we can start with. No prep veneers. When we started talking veneers back in the early 80s, and we found out not only could you make them on the teeth with composite, but the laboratory could make you a thin ceramic facing that you could bond to the natural tooth. It was amazing what we can do. We were using feldspathic porcelain back then. The idea was no prep at all. And of course, that doesn't work in all cases. So we began to prep a little bit more. And then we got a material that was a little bit, actually twice as strong as feldspathic porcelain, and that was Empress, a pressed ceramic. Only problem with Empress, and it became the rage because it was so strong, is that it took twice the prep. You had to have enough for the core, pressed core, and now they mill the cores too. And then enough to layer. You had to have 7/10 for the core, 3/10 for the layering portion. They looked beautiful at that, but they became 3/4 crowns. Then we got Emax, lithium disilicate, twice as strong as Empress, 4 times as strong as feldspathic porcelain. And you could make it thin. So we're back to where most of us are comfortable, and that is minimal preparation in many, many cases, but with a very strong material that has aesthetics. And I'm so excited about that. Of course, we've gone out now, we have zirconia oxide, which is twice as strong as that. I mean, the material's getting stronger and stronger. You really can't use zirconium for veneers. I haven't been successful there. But Emax, or lithium disilicate, is my main product for veneers today. Once in a while, we'll use a feldspathic porcelain. But because of the strength of Emax, that's what we use. And we could actually illustrate that with a minimal prep case. Would you like to do that, Brent, right now?
Absolutely, yeah. Mm-hmm. And we can talk through it and such. And so we'd love to.
Find the right one here. Okay, hang on, boys. There it is. I didn't have her pulled up. Now I do. Okay, can everybody see that?
Not yet.
You don't have your screen yet.
Okay, let me go back. I have to go back to my Zoom now. Turn the meeting, and now I share my screen. How's that?
There we go. We got you.
See, us old guys, see, we can learn technology. Just have to have millennials around us all the time, or Gil.
Definitely Gil.
So if we get the honor to treat Miss North Carolina for America, Miss South Carolina for America, Mrs. North Carolina for North Carolina America, and Mrs. South Carolina America every year. And this last year, especially the lab that we're talking to here, Frontier, helped me with these. So when these ladies win the state pageant, they go on to the the national pageant. And this was Jessie Smith from Raleigh, North Carolina. Beautiful woman. And she came to me because when they win the pageant, they get the opportunity to get a smile makeover with us. And she wanted some porcelain veneers. Now, how am I going to improve that smile, Brent? I mean, look at that.
Yeah, actually pretty beautiful. In fact, when you first showed it to me, it's like, what are we doing here? You know, we're trying to go from really good to great, you know?
Exactly. And so I'm saying, Jessie, what do you want? You have a beautiful smile. I mean, she won the pageant. Now, of course, she does have the, this little chip on the lower, which I did some composite bonding on. But what bothers her is the slight irregularity. You see the slight irregularity here in the canine, lateral, and central compared to this side. Now, this lateral is slightly rotated. She could easily have those straightened with orthodontics. It'd be no problem at all. But she's not interested in that. She wants an immediate fix because she's going to be having all kinds of she's going to go out to different places and be the queen for this year. So I looked at it and look at that healthy dentition. Now, the one thing about it, elective dentistry, I think, should only be performed in this environment because she has healthy tissue. She's and dentistry. I mean, look at her beautiful dental health. She's a candidate for it. If she had dental disease, she would not be a candidate for elective dentistry. So I said, I would be willing to do a little contouring. And basically what she wanted, if you go back to this one, she wanted a little bigger, a little straighter, and a little whiter. Again, she won the pageant with this. She's gorgeous. But I agreed to do a little minor contouring. That's all. There's the occlusal view after contouring. And if you look left to right here, can they see the right picture over there?
Yes.
Oh, this is before, and look at the minimal contouring I did just to straighten things out a little bit. I did a little bit of distal contouring in that canine, not much, and a little on the lateral, but no temporaries are necessary when you do this. That's another wonderful thing about it, is because the tissue stays healthy because she doesn't have to work around cleaning around temporaries. And then, of course, we're going to send this to Frontier Dental Laboratory in El Dorado Hills. I already had spoken to Brent about this case, and we are going to make some no-prep veneers. Now, these are EMAX. It takes a talented ceramist, in my opinion, to make a thin veneer with EMAX, much more than feldspathic. Feldspathic is layered, it's got the color inside. Here, you've got basically a single color. However, they do cut back and layer the surface. It takes a talented ceramist to do these thin veneers. So here she is back a few weeks later. We usually 0.3 weeks. I like to give the lab 10 working days. And here she's back and ready. We tried him in. I was so excited, I forgot to take a picture of it. She loved him. I loved him. I tried him in with a drop of water. And so here's just show you the placement technique. I placed the 6 front ones, canine to canine, protecting the adjacent teeth with a little metal strip there. Etch, there's that beautiful etch surface we know we can bond to. This is 7th generation bonding agents. Saturate the tooth with it, dry it, light cure the bonding agent. And then I'm going to apply some type of eluting agent. This is a flowable composite. It had a nice white opal look, so we use that on the surface. And I'm going to place the veneers. My assistant placed silane on the internal surfaces of these veneers, which were etched at Frontier Lab with hydrofluoric acid, so they had the micromechanically retentive surface. And silane increases the bond a little bit. So, and dried them and placed my eluting composite on the teeth and went straight to the teeth and placed all these. Now, I'm just going to make sure they're all seated. You can actually tack them in place a little bit and then cure. Now, I'm using a number 12 surgical blade here to get under the edge, and go back to that, of this composite, and it just peels off. And then a carbide finishing burr to get some excess around the margins. Don't use a diamond here because they can scratch the porcelain. You want to use a carbide finishing burr with light touch. And then anything interproximally, you can get an interproximal device like this, Cerisol. Then after they're polished, this is what they look like. 12. We need to go to the molars on her because she has a wide smile. Sometimes you can get by with 8, sometimes 10. Sometimes you need 12 to finish the smile. And there's her new smile. Now, again, if you look top to bottom, on the top is before, in the middle, the minimally prepared teeth, and the lower arch, the veneers in place. And she was right. There is better contour, better aesthetics after than before.
Excellent.
Smile before and after. Again, beautiful before. She feels more beautiful after. Now, I will say she came in second runner-up for the Miss for America pageant. 3rd out of 52. That's pretty darn good. And we're very proud of her. So anyway, that was an example. You know, no prep veneers are not applicable for everybody. Excuse me. You need to want bigger teeth. If you don't take anything off the teeth, you're going to add even 0.3 of a millimeter, you can have bigger teeth. So not everybody is a candidate for it, but there are a lot of people that are, and it's awfully nice when you don't have to remove sound tooth structure. So that's that case. Do you have any comments on that, Brent?
Yeah, a couple things, Dr. Nash. Maybe you can go back to that one slide where you have the 3, the pre-op and the prep and then the finals and everything. And a couple things, I get this a lot, like, you know, if we can do no prep veneers, but one of the things that's important is this, like you're saying, is, you know, number one, you have to be able to add volume. And so if the teeth are in a little bit lingual version and they're a little bit diminutive, and we want to be able to add volume to it, so we can probably do it there. The other thing too, which happens works out well, is you can see that orthodontically her teeth are pretty much in the right spot. You know, we're not going to be changing positions of the teeth very much and such. And this is a beautiful picture here of the pre-op, the prep, and then the finals there. But you see, there's really no rotations. Everything is, all the teeth are in their zone, so to speak, and that is very, very helpful. The other thing too, which is a big deal for us, is that her midline was already straight. Sometimes what happens on no prep veneers, you know, or we could say minimally prep veneers, it's very, very difficult if we have the midline that's you know, canted, and we try to have to straighten it out with porcelain without having to do some sort of prep and such. Now, I'm not saying we have to prep down to dentin and stuff like that, but there are times when we want to straighten the midline, get the teeth in the right zone. We will have to slice through the contacts to straighten everything out, and we can certainly do this with you know, staying in enamel and doing, you know, very little prepping and stuff. But it's really, really difficult for the ceramics and the ceramists to be able to pull that stuff and straighten that stuff out if it's not taken care of for you. But again, you know, in fact, when Dr. Nash showed this to me first, it's like, well, wait a minute, what are we doing and everything? And the other thing that I do want to say is, like, we even did a diagnostic wax up on the case to see if it was feasible, you know, and that's the one thing which we'll talk about more during this presentation, is that of all of the cases that I know that Dr. Nash has done and over the years and such, every single case is done with a diagnostic waxing to see, okay, where are we going with the case? And if we don't know where we're going, we don't know how, you know, what it's going to be like when we get there and such. So, so that's kind of what it is. And you know, it's one of those things you have to make case by case basis on these type of situations. And then sometimes Dr. Nash will send you some photos. I said, you know what, you got to send me the model so I can take a look and see if we can do that, and if we have to do any prepping at all. So, you know, case by case basis and everything like that, but we're more than happy to take a look at these cases for people, because obviously this is a very nice result with minimal reduction to the patient. So,
yeah, let me point out a thing. Notice, everybody, that on the gingival, let me see if I can get an after here. Sorry, went backwards. Forwards instead of backwards. All right. When you're placing or making a no prep veneer, if you don't, you have to create an emergence profile so that you come straight down. Otherwise, you have teeth that look like they're slanted forward. And so they have to know how to create a new emergence profile with no preparation. Again, that takes talent. And thank God I have you, Brent.
I got a great team that worked on this case here, so that's fantastic. Yep, good.
All right. But you know, we can go stop share. We can go a lot further than that. I mean, that was the ideal. No prep, minimal prep, new surface. That'll probably last 15, 20 years. I had mine on my teeth, although they're prepped. I had mine 21 years. So in the right environment, these can last a long time. Sometimes it takes more than a veneer. We go all the way to full mouth rehabilitation. And Brent, can I show them an example of that, of how we go from that step by step? Because it's nice.
Dr. Nash is, oops, I'm sorry. Just a little housekeeping while Dr. Nash is pulling that screen up. Keep your questions coming under the Q&A. We've got some really good questions, and we're going to get to that at the end. We may cover some of that as we're going on here. So really fantastic questions. Keep those coming, because obviously now you can see the knowledge and experience that Dr. Nash and Brent bring. Second one is, some of you have said you can't see his presentation screen. Well, I'm kind of proud, but also sad to say that we've maxed out the people in the room that can interact with us. So if there's some of you that are on but can't see Dr. Nash's presentation, we are going to record this and we'll replay it through an email or through a link on my Instagram account. So I want to make sure everybody gets it, because it looks like everybody's taking well advantage of the experience that Dr. Nash brings. So 2 housekeeping things. 1, keep your questions going and we'll get to it at the end. And then 2, you'll be able to see the full presentation at some other point. Thank you. Okay, it's all yours, Dr. Nash.
Again, that's the most conservative thing to do with elective dentistry. I love doing that. Of course, direct bonding is also conservative, but I really am partial to ceramics for longevity and aesthetics. Well, you take a case like this, and I have permission to show Dr. Hugh Doherty's picture here. He is a very accomplished dentist in Eden, North Carolina, and for some reason he felt like I could fix his mouth. He knows that he's got bruxism, that he's got the worn dentition syndrome. Look at the second molars. One of them has been actually crowned here, and it's broken already. And then the other one needs repair, probably had a composite at one time. But as you can see,
we can't see your screen, Dr. Nash.
You can't? All right, let me try this again. I apologize.
It says you started screen sharing, but we can't see your screen.
All right, let's do it again. I have to go back and bring up Hugh one more time. I need my millennials. Where are they?
Gil's a millennial. Gil's got this little thing that he wants me to fund every year. It's called Instagram or something like that. And I don't even know what a hashtag is or anything like that, but he just got this thing. I don't know. Gil, maybe you can explain this hashtag to me sometime. I don't know.
There we go. We got you now. Okay, go ahead, Dr. Nash.
Sorry about that. Yeah, Gil's an expert at that. Thank God he helps me. I've got a lot of patients from Instagram, not necessarily from mine, but from Gil's. He'll talk to you about that later. So anyway, this is Dr. Hugh Doherty. Again, a very accomplished dentist. Healthy. I mean, it's not as if he has dental disease. He's just wearing them away. And we all know that's the worn dentition syndrome. Dentists have that as much as anyone. Now, the problem is we don't know at this point whether we need to increase his vertical or not. Can we restore him at that vertical? Do we need to increase it? At this point, I don't know. Here's his protrusive guidance as he came in. He's got a little canine guidance left on the right side. This is called crossover, where it's touching in the front, not the back. That's the idea. And then on this side, though, it's all, group function all the way across, even in the crossover. So the first thing I'm going to do is take upper and lower preoperative impressions of Facebook transfer. I like the DNR system because all I have to do is send that jig to the lab, and eccentric bite registration. And I send these to Brent at Frontier Dental Laboratory, and he mounts the models for me. I ask him to mount 2 sets, so I always have that original set go back to. So he has 2 sets of mounted models. On one of them, I just ask him to make it look right. Now, again, you have to have a lab that knows what they're doing. That's why it's so important that I use a lab like Frontier, or Frontier period. But there's the curve of speed, the curve of Wilson, the 50%, the golden proportion, which tells you the lateral is 1, the central is 1.6, the canine from the mesial to the facial line angle is 0.6. All those things that we know should be there, and Brent puts them back. So if he has to open the vertical, he has to open. He drops the pin, he drops the pin. I want it to look right. And then he'll make me some of these laboratory fabricated shims out of polyvinyl that go over the wax up. And then I come back and I create what I call a fixed orthotic or a fixed prototype. Now in Dr. Doherty's case, I didn't have to take anything off those teeth. That is all on top of the natural teeth. I do bond them to place. So I put 7th generation bonding agent on the teeth, blow it dry, cure them, even the crowns. And then I go right over the top of that in that shim with the bisacrylic material, let it set, take it off, clean off the margins. All those are splinted together. So in one appointment, I have a prototype. Same thing on the upper. Now Hugh is going to use this prototype for a couple of weeks, maybe a month, whatever it takes. That's why I want them bonded to place. And you do have to cut them off there. You'd be surprised how strong bonded bisacrylic is. But now you can see he's got protrusive guidance, canine guidance. There's the crossover. You want to be contacting right over here and crossover. The other side now he has canine guidance back and a crossover contact. So basically Brent recreated anterior guidance with posterior disclusion. Also, Hugh can evaluate his aesthetics, his speech. His incisal edges are a little bit longer, so he's going to have to, can he say his F sinus is right? All that is done with the prototype, the bonded orthotic. And any changes that we need to make, we make there. And then we communicate that back to Brent. Well, I didn't have to make a single change on this one. He came back in 3 weeks and he said, Ross, what are we waiting on? I said, I want to make sure you're comfortable. He says, I'm very comfortable. I was the first day. So now we take an impression of the upper arch as it is. That becomes our new starting point. And we take another Facebook. And then we prepare the lower anteriors. Now, the way we do this at this point, some people do the entire arch, some people do one arch and the other. I have learned to do it in sections. I recreate the anterior guidance, finish that, then I go to one side, then the other. So we're preparing the lower first. I take a bite registration so we can jump that model onto the unprepared model that he mounted. And then I prepare the upper. The lowers, you can see I was able to use veneers. On the maxillary 6, I normally use some kind of a 360 design so that we can control that functional contact, porcelain against porcelain. And there's his other bite registration. Now he's got somewhere near, you know, a 2M3 color of his prep teeth, and we're looking for OM3, which is a reasonable bleach shade. Now these pictures go to Brent. We communicate with photography, and you really, really need to do that. It's very difficult to describe what you want. When the technician can see it right in front of them, they can usually recreate or improve. So here's the upper impression, the lower impression. Now, we had taken a pre-op stent just like you would any crown before, and these are temporaries made with a traditional technique with cementation. Those 6 and 6 are cemented. Now I can get those off easily. So, and then Frontier makes these gorgeous Emax restorations. Come back. By the way, we gave him all the tools he needed to keep those orthotics clean because they're all splintered together. We gave him a Sonicare toothbrush, gave him all the toothpaste and mouthwash and everything he needed because I want the tissue to look like that when we take the temps off. And then we bond these 12 to place. Now, at that appointment, or a next one, whatever it takes time-wise, we go ahead and prep one of the sides. And here we have onlays and then cemented temporaries and all Emax restorations here because these are onlays, not crowns. And we bond those to place. And then we prep the other side. So it's 1, 2, 3. Cemented temporaries, restorations from Frontier, bonded to place. So here's his new protrusive. Here's canine guidance, crossover contact in the anterior up here, right there, not back here. Again, canine guidance on the left and crossover contact in the anterior. So everything's there, but obviously we know that those restorations are in the same environment that his natural teeth were failing. So something's got to change, and he knows that, and he's very faithful wearing his protective night guard. I actually think he's watching this today.
Nice.
So there's your new smile, Hugh. He said, well, it's still crooked. Yeah, your face is crooked, pal. Good looking guy. So you see, we go all the way from a no prep veneer to full mouth reconstruction with the same laboratory. Thank you again, Brent, for that. Have you got any comments on that case?
Yeah, you know what? Actually, you know, the funny thing, you should back it up, and being sensitive that doctor is on the line here is an interesting thing, and this is why go back to the full face, Dr. Nash, if you would. So if you notice here, and this is more common than not, this sort of photography is very, very important. This is a great photo of the patient straight on, so we can see what's going on with the horizontal and everything like that. As you can see, his right eye is lower than his left eye, and probably a majority of people are actually like that. His nose is going one way, maybe an old football injury, and maybe hope he scored the touchdown on that play. And then, of course, his smile line is kind of going opposite. So he's got his eyes going one way, the smile going this way, and his nose going the other way. So one time, what happens in the laboratory, and this is what's important to have the face bow and everything, is to get what the horizontal is going to be and such. And then sometimes the fourth factor is that sometimes people kind of hold their heads a little bit sideways, you know, and so sometimes these are very, very difficult. That's why photography is very, very, very important. And kind of going back to lab communication and such is that Dr. Nash always gives me photos. Now he's old school. He still prints his photos out and sends them to me, but the nice thing about it is he draws on them what he likes. And I have still a few people doing stuff like that. Some people they'll send the photos to us through Dropbox so we can get can see everything. But generally, the photos that people like, people always ask like, what photos? Full face. Full face with a face bow, a stick bite if you want to send a stick bite. Close up with the cheeks retracted, and then right lateral, left lateral, and even a full face retracted as well too, as we can do that as well. And of course the prep photos which you sent us, which are very important as well too. So the nice thing about the photography is that you can, digital photography, you can take as many photos as you want and just send them to us. Either print them out like Dr. Nash and a few other guys do, or send them through Dropbox. Furthermore, as we move into this, what we're doing right now is we're having, a seminar with 100 people in here online and such. There's a few other doctors that are doing this. I know Dr. Rob Soto does this a lot. He actually takes videos through a website called Loom, and he walks through the cases with me and then records them. So I don't have to get on the phone with him. My technicians don't have to get on the phone with him. He sends us that little, usually like anywhere from a 2-minute to a 4-minute type of video that he does, and shows me what he wants, talks to patients. He can pull the patient photos up there and everything. And the beauty about that is that we can talk about the intangibles about the case and such. And so then we have that, and we can watch it over and over and over again. But even then, once, with Dr. Nash and I, besides I kind of like talking to that guy anyway, we'll call up, we'll go through that and everything. And we start to kind of, understand each other. And my smile designers, Trevor, Pedro, Catherine, Frank, those guys know their doctors, know their teams, and then they pretty much know what's going on with it. And then, but I still think it's good to have, anywhere from a 3 to 10 minute conversation with somebody with the case in front of you and such. So, but it all starts off with good preparations and good photography and such. So yeah, good stuff.
Thank you, man.
Mm-hmm.
And probably, Gil, if I'm right, we are on to the marketing section. Am I correct?
Sure. We'll talk about that. And right now we've got about 13 questions going on, so you can take your screen share off. So just keep your questions coming. My colleague Zach is printing those off, so we'll get to all that, and that'll be a really good intimate Q&A with Dr. Nash and with Brent. So let me just talk a couple of minutes about marketing your practice. I'm very fortunate that I get to run across a lot of practices on both coasts and in between. But one of the things that I see that's really important in how cosmetic dentists separate themselves is this. And I'll kind of tell it in a way of a fable or a story, right? So let's pretend I'm Gil the patient, okay? I'm Gil the patient. I've been thinking about veneers for a long time and just finding the right time, etc. I've been going to Dr. Brent, my favorite doctor. My whole family's been going to Dr. Brent for the last 6 years since we moved to El Dorado Hills. And I love Dr. Brent. Every time I go there, he gives me my little goodie bag that I've got my floss, my toothpaste, and Dr. Brent's name on the toothbrush and everything. And I follow all my recalls. My whole family goes to him twice a year. Love Dr. Brent. So, but I've been thinking in the back of my head about these veneers. And so I go to church the following week and I run into my buddy Rick, okay? Good friend of mine, Rick, and we golf together and all that. And Rick got new veneers. And so I started getting in a conversation with my buddy Rick, and I said, man, those look awesome. And he starts telling me all about it. And he says, you know what? The doctor that did this is Dr. Smith, that's down the street from your office building. And Dr. Smith, here's what he charged me. Here's what he did, 10 units, blah, blah, blah. What do you think, Gil? And of course I say, man, Rick, those look awesome. Who's that doctor again? Smith. So now I have a moment of truth. I have a decision to make. In my mind, do I call Brent? I guess he's there. Do I call Dr. Brent or do I call Dr. Smith? I would use Dr. Nash as an example, but he's in Charlotte. But there's some people that will fly across the country for that. But in this case, it's my local community. What do you think most people would do? What would you do, Mr. Nash, if you were in my position? You're not the doctor. What would you do? Would you call Dr. Brent, your regular doctor, or would you call Dr. Smith to talk about your veneers that you're going to be spending $12,000 on?
I don't know.
Exactly. But most people, I would say 75% of people at that moment of truth will call Dr. Smith rather than Dr. Brent, right? Every time I've gone into Dr. Brent's office, he's got this beautiful waiting room with a landscape, a beach, a whatever, right? Dr. Smith, I looked him up on his website and he's showing all kinds of things about cosmetic dentistry. His waiting room has a gallery of before and afters and everything. So in my mind, at that moment of truth, I'm probably going to call Dr. Smith. So the moral of this story, the moral of this fable is your practice has to reek of cosmetic dentistry if you expect your patients that when that moment of truth comes, when that time comes, you want them to know that you're the expert. You're the one that does this. When I go into Dr. Nash's office in Charlotte, in Huntersville, what do you have lining your hallways?
Pictures.
Pictures of smiles that he's done. So that's planting seeds in my head. Not in these times, but if he was going to In-N-Out Burger this afternoon, he would probably want to do some kind of a story, a hashtag story, a geotag story that says, hey, I'm Dr. Brent at Frontier. Because think of it this way. If Joe, the regular guy happens to be on Instagram and he sees a story with Dr. Brent at Frontier, Dr. Brent at In-N-Out Burger, he's going to remember that. And when the time comes when he has a toothache, whatever, he's going to say, oh yeah, I remember that Dr. Brent did at In-N-Out Burger. He must be nearby. Let me look him up. And then boom, he's got a client. The other thing that we do at Frontier, and you know this, Dr. Nash, and I'm going to finish up here and maybe you can fill in. The other thing that we do at Frontier is we promote our doctors heavily. We only succeed when you guys succeed, right? So we promote our doctors. We do a lot of back end that you guys don't see of direct to consumer marketing, and that's how they've come to Dr. Nash. We promote our doctors on our website. We promote when they work. We promote their work. So it's really all about our doctors. If we can make them successful, then we'll succeed. So let me pass it on to you and then we'll get to our questions. What has Frontier social media and marketing done for you, Dr. Nash? And if you have specific cases.
You know, I just this week, I can tell you, we just opened up this video console, and listen, everything's changing. You were ahead of the curve there, Gil. But after all this gets done and we're back to work, it's not going to be the same. What's going to be different is we are all learning to communicate through social media with a lot more people. Anyway, this week I had a young lady that went to our site and said she would like to have a video conference with me. And so I did it on FaceTime. There are other ways to do it now that I've found out, like Revenue Well, and it's amazing what you can do. But anyway, and I said, I always ask patients, where did you find me? And she says, well, I found you on Instagram, but I really didn't find you on your Instagram. I found him on this guy named Gil from Frontier Lab. And because of that, she called me because she saw something that he promoted about me on his Instagram. I also got a patient from Iraq, a soldier lady that was coming back, and she called me personally and said, I like your work. I'd like to come see you when I get back. I said, how did you find me? I went on this Instagram and deal somebody, you know. So it's amazing what's happening there. And this man, I think I'm pointing to you on the screen.
You are.
To my left, okay? He actually got me to open an Instagram account. Now I have a couple of thousand followers. I think you must have 100,000 followers. I don't know. But it's an amazing tool. I post on it almost every day just to get the information out there. And I've got lots of friends and patients from there too. So it's a marvelous thing, Gil. Thank you.
Okay. Thank you, Dr. Nash. So let's get to the questions. You guys have put in a lot of questions. Keep them coming. And then I'll leave the answers to Dr. Nash and to Brent, okay? One last thing about marketing and Instagram and social media. And Brent has heard me say this comment over and over and over again. All we're doing is throwing breadcrumbs out there, right? We're just throwing out breadcrumbs. And our hope is, I don't care if I have 10 followers, 10,000 or 100,000. All I care about is the one follower that picks up my breadcrumb that says, hey, I'm going to give Gil Frontier Dental a call about your services. So just keep that in mind. Don't get so caught up in the numbers. Make it organic, make it genuine. And let's make sure that we're just throwing the breadcrumbs out there, because it's really not costing you anything. Okay, let's get to some questions. We already got the sharp red tie and pocket square. Here's a question from Dr. Ashish Patel. Thank you for doing. Brent, tell us things that would be helpful for us to focus on communication easier on cosmetic cases, such as top 10 reasons the lab has to call the doctors. So that one's for you, Brent. Okay,
so really, thinking smiles on cases, even like, a regular crown and bridge as well too, at the very least, the smiles line cases, the first one's coming in, starts off with the diagnostic wax up. Like Dr. Nash, he always does a diagnostic wax up. When the diagnostic wax up comes in, talk to your smile designer about what you want to do, rather than just say wax 4 through 13. Do we want to lengthen? Do we want to have square? Do we want to have rounded and such? And so that's number one. And because we're going to be calling you anyway to find out what type of style you want. The second thing is too, is that what we do when we first start working with somebody, and even some of the people we were working with for a long period of time, during this downtime, it's probably not a bad idea to contact your smile designer. Go over the preferences. We have some defaults that we have at the laboratory, as far as how you want your occlusion, how you want your contacts and stuff like that. But there's a list of questions that we set in people's preferences to specifically, want. Do you want us to adjust the ponic site? Do you want us to make it your crowns in occlusion and things like that. Usually the main, there's I can't go through 10 right away, but I think that some of the ones that would be, it's like usually a clearance type of thing. But the other thing is this too, is that get used to working with your smile designer and start using the phone to text on. We can just text you real quick and just have questions like that as you're going from operatory to operatory. You can answer that real quick and such. But again, it's always good, even if you don't have a smile design case, if you have some posteriors, get to know Frank and Pedro and Trevor and Catherine, and just shoot us some text messages and such, and to kind of like talk to them and stuff like that. And it's going to really help even for some single units. And then when you get to a big case, you're already understanding who you are and such. So kind of a quick little answer there for you, Dr. Patel.
Okay. Thanks, Brent. This one looks like it's for you, Dr. Nash. Is it possible to get a list of Dr. Nash's materials and bonding techniques?
We actually have those at the Institute. Now, we teach 3 courses there. I teach 3 clinical courses: direct composites, indirect restorations, and full mouth rehab. And they're all 2-day hands-on courses. We do have a materials list in that case. As far as the clinical technique, that has to just go by watching the experience and different cases and things like that, because it can be a little different for different cases. But we do have materials lists you can get. But if you contact us at www.thenashinstitute.com and you can leave questions, we'd be glad to get back with you.
Perfect. Okay, very good. Another one for you, Dr. Nash. Did you place cement in the intaglio of the veneers as well, or only on the surface of the teeth?
On that, the no prep case, only on the surface of the teeth. Now, that doesn't mean that's the only way to do it. Sometimes we put it inside the veneer itself, and sometimes we put them on both. But I found that a nice technique for these no prep veneers with light cured eluting composite like that is to place it on the teeth, because then it's not so slippery getting it over to the tooth. So it doesn't really matter how you get it there, but I placed it on the tooth in that case. Sometimes I place it inside the intaglio surface.
Okay. Another one for you. Do you clear occlusion with no prep veneers? In her case, how did you address canine guidance, or did you remove it for occlusion?
She already had the proper guidance. We didn't change that one bit. All of her function was still in her natural teeth. And when she went into crossover, she did have some contact on the anterior centrals, but it didn't change her occlusion at all.
Okay. How do you finish interproximal with no prep veneers?
How do I finish them? Uh, well, obviously, we're not breaking the contact. So as you can see, I use a multiple placement technique. There will be some residual composite, and we remove everything we can with the carbide finishing burr and the 12 blade. And then whatever small amount we have in between, we need some kind of an approximate, we call them saws. I don't like to use the word saw in front of the patient, but just push it out. It's not to saw it out. And if you have to start sawing in approximate to get that out of there, stop. You're going to break something. It has to be very thin, and you do that with your burrs, and the edge of that little saw, the teeth just get a grasp, a purchase on the material, and you just push it out.
Okay. Just a note, we may run over just by a few minutes. I've got a few more questions, but I want to make sure we cover everything, and we want to be respectful for your time. So it might just be 5 or 10 minutes over. Okay, another question. Can you cover hypocalcification white spots with minimal prep veneers?
Yes. Yes, you can. If you want bigger teeth.
Okay.
Remember, teeth are going to be bigger if you don't prep them a little bit.
What's the average thickness of the no prep veneers from your standpoint, Dr. Nash?
How thick are they?
Mm-hmm.
0.3 of a millimeter.
Okay.
I mean, they can be thicker if you want them to be.
And Brent, that's enough to mask any underlying substructure.
Yeah, it depends. I mean, if you have really dark tetracycline stain, obviously the thinner you get, it's going to get a little more translucent, even with the Emax ingot that we use and such. But, you know, for the most part, we can get those down pretty thin. What we'll do is we'll press them thicker, and then we'll thin them out and everything. They're very, very, very delicate, you know. But the nice thing about it is the Emax is stronger. Empress, when you get thin, you tend to place it, it can crack, you know. And so, in fact, sometimes on the no prep veneer cases, it's not unusual for the first time the doctor's first case they do that, when they go to push it in, they crack them. So you have to be very, very careful, you know. Can't be heavy-handed.
That's why we like Emax rather than feldspathic.
Yeah.
Okay, good. You mentioned emergence profile. Is that all on the lab, or when or how do you determine if it's possible to do so without prepping? In other words, what is the minimal thickness necessary to ensure the material won't fracture? I guess you covered some of that, Brent.
Brent, I think we're back to 0.3, and that's why you don't want a thin margin. You want one with a little bit of emergence profile, and you want that anyway, so you don't have teeth that are slanted forward. You want them to come out and down.
That's right. It's got to have a little bit of volume coming out of the tissue and everything. And people that have done cases before, we do a model that has a pink tissue rubber type of thing. So that way we can simulate the veneer coming out of the tissue with the pink tissue model. Very helpful.
Very good. On the prototype, after you bond and place temp on top, do you break contacts?
On the prototype, no. It is a continual stent all the way around. They're all hooked together. That's why you need to finish them so that the patients can get in approximately with some kind of device. We give them a little, what do you call them? Interproximal cleaner. And, okay. But no, it's one complete arch. And then when we go back to prepare the 6 anteriors, I'll section behind the canines and then prepare the anteriors.
Okay. When do you recommend making a bite split? At the end?
On a case like this, when you have the worn dentition, bruxism, all that kind of stuff, we're planning it from the beginning.
Okay.
I didn't need a night guard for the beauty queen for those no prep veneers. There was no reason. She didn't have any functional problem. They were beautiful. But as you can see, with Doherty, no question about it, we're going to have to protect those.
Okay, very good. What camera do you use for your photography, Dr. Nash? I mean, we could do a whole session just on that, but.
Yeah, I use the Canon. I think it's a D80 with the 100 millimeter macro lens and a ring light. I get them from Norman Camera. They're all set up to go. It's a cookbook.
Okay. Why do you want canine guidance and not group function when restoring? Wouldn't canine guidance cause potential fractures or debonding?
No. Again, that's the philosophy I studied under Dr. Pankey and Dawson. And I just believe in anterior guidance with posterior disclusion. That doesn't mean group function doesn't work. Now, if I'm replacing a crown on somebody in the posterior or doing a restoration there, I'm not going to change their entire guidance for a single tooth. They're doing fine. But if I've got the opportunity through reconstructive dentistry to recreate anterior guidance with posterior disclusion, I'm going to do it. Think about it. You can put 200 pounds of force, 200 pounds per square inch force on your second molar. You only put 70 out here. So you want the force to the anterior. It's just better for everything. And the patient has good occlusion when you get through. I don't find a lot of fracture due to the guidance. The guidance has actually helped.
If I can jump in on that real quick, Gil, is that's the beauty about when Dr. Nash puts the people in the full mouth temporaries and lets them sit there for a few weeks and such. If there was a problem, they'd be blowing off the temporaries right away. And then Dr. Nash would contact me and say, hey, we have to rethink this thing. Okay. The temporaries, and it's pretty strong, but it's plastic after all. So, if it works in plastic, all we're doing is just changing the plastic into porcelain. And if it works for plastic, it's going to work for porcelain. And I can really say that, very, very, very rarely do we have to remake anything because it's broken. Because Dr. Nash takes the time to work out all the occlusion in the temporaries first, and then all the hard work is done in the wax up and the temporaries, and then we just change it into porcelain.
Okay, good. Here's one. I'm combining two questions. Could you use a stick bite instead and get same results as a face bow? And is there a good online tutorial on how to get an ideal face bow recording?
A stick bite can work. I wouldn't use it on a full mouth case where we're changing vertical and all kinds of angles. It could, for instance, on Jessie's, all he needed to know was the horizontal and vertical position, because we're not changing anything else. But when I am going to be doing some alteration of vertical occlusal changes, I want a face bow transfer.
Okay. Just a few more questions. I see people are starting to drop off. After delivering your case, how soon do you see your patient for post-op check occlusions, photos, et cetera, after final delivery, happy visit, et cetera?
Great question. We always, and we repeat, always have our patients back at least 2, maybe 3 weeks later to make any final adjustments. If they need something before that, I tell them to call me. But I do want them to experience the new function. And there are usually some little places that we're going to alter. So yes, always post-operative 2 or 3 weeks later. And we actually have them in for complimentary prophy, and I do my adjustments at that time.
Okay, last question, clinical, and there's a few social media questions and we'll finish up. Does Dr. Nash apply pressure to the veneers when tack curing the veneers, or does he place them and wave cure all of them?
I tend to do the multiple placement technique. Now, I know some very good dentists who place these one at a time with warm composite. It takes all day long. It takes about an hour or two to do it. I can place those upper 12 veneers for Jessie in about 2 hours with multiple placement technique. To me, it's more efficient. It works better. And give me that question again. I got off.
Does Dr. Nash apply pressure to the veneers when tack?
Right. And again, I could place all 10 at once, but the trick is to make sure they stay in place before you cure it. So I usually go 6, 2 and 2 is 6, 3 and 3. And I can see all 6 front teeth, and I go back and forth with that little instrument you saw. That was a optroscope pad by Ivoclar, just to make sure they're staying in place. And then I don't have the operatory light on at that time. Now I put the operatory light on. That's usually get my tacking effect, and I keep going back and forth and make sure they stay in place until the composite starts to gel a little bit, and then I don't have to do that anymore. You can do that with a light yourself and just a light tack back and forth, but then sometimes it's a little bit too much. So I usually let the operatory light do it.
Okay. All right. So just the last couple questions, and these are social media related, so I'll take those. Here's one. No question. Just wanted to say hello to everybody and miss you guys. Absolutely. This has been really fun to be able to talk to everybody and feel a little bit social. We're socially distant, but we're obviously right here with each other. So thank you for that. Gil, would you recommend an office IG account or personal doctor-only account? My best answer to that is think of what you want your community to think of you. So I know for Dr. Nash, I recommended Ross Nash DDS, right? Joyce the dentist, Lauren the dentist, Mike the dentist. You want somebody to know instantly when they run across your account, see teeth, see you at In-N-Out, that you're a dentist. So I would recommend an office IG account, but throw in some personality, throw in, stuff about you, what you did with your kid. Basically, it's allowing the community, your patient base, potential patient base, to know more about you. Show your dog. What do I do on Instagram? I show a heck of a lot of teeth. I show me with a heck of a lot of doctors. I show me with Brent. I show me with my dog. I show me eating whatever, right? Because I want people to know me. In fact, when I visit a doctor in South Carolina or in Florida, when we see each other for the very first time, they feel like they know me already. I know them already. And it's really a beautiful thing. So I hope that answers your question. Next one, and this happens to be one of our clients. So Gil, I love this story. So that was our fable of my buddy Rick and Dr. Brent. Do you have someone like yourself to recommend to use for social media marketing help? I'm not so good at it, and also I've not come across anybody who can be really good at helping. Or maybe where do I learn how to be more active on social media? And it takes a lot of time and don't do it as often as I should. So let me answer that. There's a couple questions in there. Be careful of the people that say we can do social media for you. You're going to spend $300 to $500 for somebody to manage your account, and it becomes very generic. I sometimes scroll on my feed, and there's 4 of the same pictures of Happy Doctor's Day or whatever the case might be, and that's one where it doesn't show you being genuine. So I'd be really careful about that, and that's really the most important thing with social media is who you are, what you do, and what can you do for me. So when you run across a company that promotes an Instagram service, is it allowing you to show yourself being genuine to the community and answer those questions? Who you are, what can you do for me? Let me get a chance to get to know you, okay? Where do I learn to be more active on social media? I would just follow some dentist accounts, dental accounts, and see what they're doing. And if it resonates with you as a consumer, then that's probably be a good account to follow. I mean, that's what I did. I looked at a bunch of accounts, who resonates with me, and I just kind of took all those things. In fact, this is interesting. And again, the person of this, and I'll contact you afterward, happens to be a client. I do several a week of FaceTime chats with our clients. It's a service that we offer to Frontier. I figure what's our goal again? If we can help you succeed, we'll succeed. So I actually do a 30-minute FaceTime session to get you through the learning curve of social media and get you up and running. So I mean, I've been offered jobs to run people's accounts and everything, but obviously I'm too busy with Frontier Dental. But I can certainly help you. I'll spend 30 minutes with you. If you're a client of ours, potential client, we'll spend some time together to get you through the learning curve. Okay. So I hope that answers that question. Okay. Here's another one. Let's see. We're almost done here. Just a couple more. Not a question, just wanted to say how glad I am I came across you guys over social media and Gil's page. You've made the process of working with a complex full hab rehab case very easy, so I want to give you props for that. Looking forward to the case as soon as this is all over. And then I think this is our last, more messages are coming. How lucky was I to meet Brent at UCLA in 1998 at the Continuum? We had a great partnership. Brent and Frontier helped make me a good cosmetic dentist. Brent, you're going to be really happy to hear this name. That's from Dr. Robert Horenkamp.
A retired dentist and a great guy, and we can't wait till baseball season gets going again. He loves his Cardinals, and I love my Giants.
And where's he from, Brent? Where's Dr. Horenkamp from?
He is from Illinois.
Illinois, yeah. Of all places.
He's a Cardinals fan, not a Cubs fan, and we talk about that all the time. So.
Okay, here's one. Thank you for your time. This one's fantastic, and I'm going to name who it is because he happens to be one of my faves right here local. Just received my Frontier veneer case a few minutes ago, cementing on Monday, planning to use Dr. Nash's Uplight technique. Thank you, Dr. Nash. Okay, Dr. Sean Pierce of Pierce Aesthetics in Costa Mesa. Thank you very much. Okay, I think that's it. So anyways, I hope you all enjoyed this. This certainly was great for us. Thank you. That's my parting words, is thanks for your time. And we certainly look forward to working with you now. We are operational. And most importantly, when we get on the other side of these unprecedented times that we're on, we hope we can get back to normal, and wish everybody success. Dr. Nash, anything from you?
I'm just glad to be a part of this. Thank you for having me, and thank you all for listening and watching my work. Obviously, it's my passion. I can't wait to get back either. As a matter of fact, I'm tired of cleaning the house.
Do you think we should continue this with some specific topics with Dr. Nash? Just message me. I'll work it out with Dr. Nash and Brent. You know, we kind of did the overview this time around, but if there's something specific, we'll certainly be happy to do this again. While I have the floor, before I hand it to Brent, I want to thank my colleague, Zach at Frontier Dental, for doing this. In fact, a message just came up. We hope we can do more of these with Dr. Nash, but Zach has been very helpful and instrumental for getting us on here. So thank you, Zach. Brent, Frontier Dental. Go ahead,
Well,
Brent.
thanks, guys. And thank you, Dr. Nash, for doing this, and Gil putting this together and everything. And thanks to, Dr. Nash, it's me, but I got an incredible team here that really does it all. I get all the credit, but the team is the one that does it all. And across our 3 laboratories, Frontier in Vancouver, British Columbia, Nord Dental Laboratory in Milwaukee with Frank, Dan, DJ, and the boys, and all my guys here at Dorado Hills. So thanks to everybody. Everybody be safe, and we're looking forward to getting back up and running again. Okay.
Hey, thanks everyone.
See you.
All right, guys.
Okay.
Thank you. Bye-bye now.
Bye.
Bye-bye.